Good afternoon or good morning, depending where you are. I'm Fabio Archimasco. I'm directing the Implementation Science for Innovation and Discovery series here at Medical College of Wisconsin. Welcome to our February session on implementation science. I'm glad to introduce today a guest speaker that we have. This is Dr. Obinna Ekwunife. He is coming from University of Washington in Seattle, so he's joining us remotely by Zoom. But I also wanted to share with the group that he will be joining our faculty in June, end of June, right? So welcome. We're very excited to have you as part of this series as one of the speakers. Dr. Ekwunife is going to be talking about utilizing private sector resources to ensure sustainable HIV programs, piloting pharmacy-based services in Kenya. Just to give you a little bit of background about Dina, he's an experienced health economist with additional skills in implementation science, evidence-based public health, and data science. He is currently examining differentiated models of HIV service delivery, which include self-testing, pre- and post-exposure prophylaxis in sub-Saharan Africa. He's ardent in assessing and identifying cost-effective health interventions for deployment in healthcare settings. He was trained in global health, particularly in ways to mobilize, allocate, and manage scarce resources. So without further ado, welcome Dr. Ekwunife, and go ahead, start the presentation.
Okay, thank you very much for having me. Obinna Ekwunife. So I'm a postdoctoral fellow at the Fred Hutch Cancer Center at Seattle. As you have been told, I'll be joining Medical College of Wisconsin in 1st of July. So I want to talk about the implementation science project that we have been working on, which where we try to enhance the delivery of HIV pre-exposure prophylaxis, utilizing private pharmacies to make PrEP accessible. So today I'm going to, again, we are going to go through, I will talk on implementation science, some basic ideas we have. I will also talk on how to achieve pre-exposure prophylaxis delivery at scale, utilizing differentiated service delivery. Then I will zero down on pharmacy-based PrEP delivery implementation science project that we have been working on. So on implementation science, we know that from original research to implementing the findings of that research takes through various process. And as a matter of fact, it takes an estimated 17 years to turn only 14% of our original research to the benefits of patient care. And this brings us to the concept of the no-do gap. So we have advanced in medical science, but that advancement have outpaced their application. We have almost more than 10 million annual deaths from diseases with proven low-cost prevention or treatment strategies. We have the strategies to treat these diseases, but it keeps on affecting us. So we have like 1.7 million TB-related deaths annually, 1.1 million HIV-related deaths, 6.6 million preventable child deaths, and 300,000 maternal deaths annually. And we know how to, treat these diseases. So the no-do gap. An example of the no-do gap is when we look at HIV. Yeah, we have the treatment for HIV, and we have how to diagnose, identify new HIV cases. But as even with that, only 84% of people, only 84% of people living with HIV know their status. And only 73% of people living with HIV are on treatment, while only 66% of people living with HIV are virally suppressed. when we look at the translational highway and where implementation science falls in this highway, we know that in this highway, we start from discovery. That's where we identify mechanisms and targets, identify new diagnoses, treatments, and prevention methods. We have the second stage where we test new interventions in a controlled environment and establish an evidence-based intervention. Implementation science falls in T3, where we explore how to deliver evidence-based intervention in real-world settings. And of course, we talk about the T4, where we study influences of health of populations. One key thing we try to solve in implementation science is implementation bottlenecks. And we know we have these bottlenecks for example, in primary health care services, in vaccine delivery, in maternal and child care, in drug therapies, and even the new services we develop like PrEP, option B plus, voluntary medical male circumcision, and all that. We have implementation bottlenecks. An example is when I look at my country in Nigeria, as of February 2023, in COVID vaccine coverage is still at 30.5. The vaccines are available, but the issue is how to deliver these vaccines to get to people, to Nigerians. So implementation science, we define it as a systematic scientific approach to ask and answer questions about how to get what works to people who need it with greater speed, fidelity, efficiency, quality, sustainability, and relevant coverage. Perhaps the key words we have to look at here is first, what works? That is the evidence-based intervention, and how to deliver that evidence-based intervention, which is the implementation strategy. So in implementation science, we identify an evidence-based intervention and then study how to implement that evidence-based intervention. So we define evidence-based intervention as programs, practices, principles, procedures, products, pills, and policies that improve health behaviors, health outcomes, or health-related environments. That is the what. While implementation strategies are actions to enhance the adoption, implementation, and sustainability of evidence-based interventions. That is how to deliver it. So implementation science uses different methods in identifying how to enhance delivery of interventions. So we use impact evaluation, economic evaluation, qualitative research, operational research, system analysis and improvement, organizational readiness for implementing change, stakeholder analysis, which is, for me, very important to engage stakeholders, dissemination research, social marketing, surveillance, and data science. All these methods we use it in implementation science. Again, when studying implementation science, we typically start from evidence-based intervention or practice. We identify strategies for implementing that evidence-based intervention, which can target the system, environment, the organization, could be group learning, supervision, individual providers or consumers, and we measure implementation outcomes and a bit of service outcome and client outcome as well. So the key area where implementation science study falls is between implementation strategies and measuring implementation outcome and a bit of service outcomes. Okay, so this is like a primer on implementation science. I'm sure we already have this we know all this. Now, how do we achieve PrEP, pre-exposure prophylaxis, HIV pre-exposure prophylaxis at scale using differentiated service delivery? So one thing is that achieving PrEP delivery at scale is important in these moments of global HIV epidemic. Generally, incidence of HIV has fallen in, especially most of South African countries, but there's still some new infections happening. And if we check the figure on the right, we find that in Kenya, that yes, new HIV infection fell, but we are still not at goal. So we are hoping in 2022 to be at 18,000, but we had like twice that new infections. So this is the problem we wanted to solve. How do we improve, enhance HIV prevention with the tools, with evidence-based tools that we have? So we worked with Kenyan researchers from Kenya Medical Research Institute, as well as partners in health and research development in Thika. Meanwhile, Kisimu, Kemri is in Kisimu, while partners in health and research development is in Thika. Kisimu has one of the highest HIV prevalence in the country at 17.5%. So again, another lessons learned from antiretroviral therapy delivery is that suggests that we have to simplify HIV treatment and prevention services. And this is what DSD is all about. So DSD is defined as a responsive, client-centered approach that simplifies and adapts HIV services across the cascade to better serve individual needs and reduce unnecessary burdens on the health system. So the key word here is to simplify HIV treatment and prevention treatment services. So what do we simplify? We simplify who offers this service. So instead of using the overburdened physician, so clinical officers could do the work, nurses could do the work, pharmacists could do some of the work, can involve community health workers, we can involve peer to do some parts of the work, and as well as HIV counselors. So what can be simplified? We can simplify PrEP initiation and refill. So instead of every month, they come every 3 months or every 6 months. We can simplify adherence support, the HIV testing. They can use, for example, HIV self-test. We can simplify STI screening and all the services. When we can simplify access to these services. So instead of visiting the hospital monthly, they can do that every 3 months, every 6 months. We can also simplify where they access this service. So instead of coming to the HIV clinic, they can go to family planning clinic, or the service can be delivered in private clinic or in private pharmacies at home. We can use online consult, we can use courier and all that. So our as I said, I work with Dr. Katrina Oblat's team at Fred Hodge. So this team developed a couple of different DSD, differentiated service delivery model for PrEP delivery. So the first model is the JG PrEP study, where we try to simplify when people assess PrEP. So instead of every month or every 3 months, they come every 6 months. But we give them HIV self-test so that they test themselves at home to make sure that they are negative. We also developed peer PrEP referral model, where young adolescents, girls, and young women that PrEP introduce their peers to their peers that need PrEP to PrEP services. So we give them HIV self-test. Of course, we give them, we train them, give them basic information that they have to transmit. Then with HIV self-test that they give their peers, then connect them to care. Then finally, we developed pharmacy-based PrEP delivery, which is delivering PrEP at private pharmacies. And this is what I'm going to talk about in the rest of my talk today. So pharmacy-based PrEP delivery. So what is the issue? Why do you want to deliver PrEP through the pharmacy? So we know we have PrEP, which is an evidence-based intervention. It works, especially when you adhere. Adherence is optimal, and the dominant model of delivery is in HIV clinic. Actually, in most countries in Sub-Saharan Africa, PrEP is available oral PrEP is available in the hospitals, in the clinic. But the problem is that people find it difficult to go to the HIV clinics because of stigma associated with visiting HIV clinic. Is really very strong, by the way. If anybody used to the health systems in many sub-Saharan African countries, you know that it spend a long hours in those hospitals. There's limited hours of operations, there's overcrowding, multiple prep stops, as well as costs associated with using doctors to deliver these services, as well as clients' time, because they waste a lot of time and miss income. So the long and short is that PrEP is available, but people that need PrEP do not have access to oral PrEP. So that's what our group, my research group, tried to solve. But luckily, even Kenyan government has already prioritized pharmacy PrEP. So they identified pharmacies as an avenue to deliver PrEP in their one of their documents released by Ministry of Health as in 2017. So we sought to solve some key evidence gap about private pharmacy deliver PrEP services. So first question we ask is, how do we do it? So it's Kenyan government identified that is a good means to deliver PrEP, but how can it be done? How can PrEP be delivered legally in private pharmacies? So we looked at a model already running in the US Cross Pharmacy in Seattle. So we borrowed this model as a starting point. So we did some formative studies to understand what Kenyans want, as well as we sought stakeholders' input. So through nominal group technique, we invited some key stakeholders and people that will likely to receive PrEP through pharmacies in a one-day meeting, presented our findings from the formative study, as well as this model. So we asked them to identify the bottlenecks, try to think through this model and identify the possible bottleneck that this model will face when it's implemented in Kenya, and as well as the solution, because we know there are problems. So our idea is, we know that there are problems, or how can we surmount these problems? So they came out with the problems that they saw, as well as the solutions. Those solutions, we grouped it into short term, the ones we can easily change to implement this project, and the ones that we need to change some policies. So this is the adapted step care model. So the key thing about this model, there are three key workarounds. So pharmacists prescribe this PrEP, but they use a standard checklist. So there's a checklist that guide them towards identifying people that qualify to receive PrEP, as well as there's a remote clinician that they can call at any point in time that things are unclear. They call to get a support for that. Then secondly, we used HIV self-testing, but the trained pharmacy provider guiding them through the process, so to make sure that the pharmacy clients interpret this test correctly. So lastly, we linked the pharmacists to the public health hospitals where these PrEP commodities, PrEP and HIV self-test are available. So the pharmacies access these free commodities from the public hospitals where they're available and report to them. So the second question we ask is, if you build it, will people come will they come? So what does PrEP initiation and continuation look in this setting? So who initiate PrEP and continues PrEP in the pharmacies? So for that, we carried out 2 pilot studies in Kisimu and in Thika. So for pharmacists to be eligible, they must have a private room and they must be licensed by the pharmacy board in Kenya. and also they must have a full-time pharmacy provider. It could be a pharmacist, a pharmacy technologist. Then for clients to be eligible, they have to be 18 years or above, and to recruit people to popularize, to advertise these services, we placed posters in the pharmacies. Pharmacy providers also talked with people that they feel that they are at high risk of HIV, as well as people already receiving services to talk with their friends, so word of mouth. So as I say, the commodities were obtained through the public hospital. So Ministry of Health already provides these medications to the public hospitals. So the pharmacies were linked to the public hospitals. So the outcomes measured PrEP initiation, continuation, acceptability, cost, and safety issues. So we carried out the first pilot for 12 months, and for that we used oral HIV self-test. And after the 12 months, we identified a lot of issues. We made some modifications and adaptations, and we also we extended this pilot for another 6 months, implementing those new modifications and adaptations, which included, instead of using, we introduced PEP, because we felt that some people might not necessarily need PrEP to be on long-term prevention, but they need PEP, as well as STI testing, because some people also need to be tested for other sexual transmitted illnesses. Then we introduced, instead of using oral fluid HIV self-test, we changed to blood-based HIV self-test. In the pilot study, we charged the client some fee, 300 Kenyan shillings. But in the pilot extension, I wanted to see if the initiation would be if this service is free. Yeah, it was implemented for 6 months. So these are the typical pharmacies where we implemented the studies. And if you see, for example, on the left, this is our poster showing that PrEP could be accessed there. So this is how we demand. This is one of the demand generation ways we generated demand for this service. Okay, so the PrEP the PrEP initiation was one thing we found out is that PrEP initiation was high in both pilot studies. So in the original pilots, we got a PrEP initiation rate of 58%. And in the pilot extension, we even got a higher initiation rate. Of course, remember I said that the pilot extension we offered free, the service was free. So that might explain why we had higher initiation rates. And another thing we saw is that private pharmacies may reach a different client population than public health facilities. So we just looking at the demographics of people that accessed these services and comparing it with some PrEP demonstration studies conducted in public hospitals, we found out that private pharmacies reached more younger people less than 25 years, and people that were unmarried. As well as if you look at the HIV risk and behaviors, private pharmacies reached people that inconsistently use condom, that had partners with unknown HIV status, and had multiple sex partners. So and it made sense because public hospitals, more or less, were serving people in discordant populations that are more in stable relationships. But while private pharmacies will reach more younger people, which it's one of the hypotheses we also thought that we will achieve. Another thing we also saw was that the PrEP continuation at pilot pharmacies was high, as the continuation was in the pilot was any continuation at all, because some people stop and restart. So any continuation at all was 55%, while in pilot extension it was about 72%. So when we compare the pilot initiation and continuation with the other implementation projects carried out in public hospitals, we think that our result is really comparable. I will even say that the pre-initiation in pharmacies were a bit higher. If we add some studies that focused on AGY, that's adolescent young girls and women, it's also the same. So this nurse navigator is another Gillian Pinter study in pharmacy, but they involve nurses to deliver PrEP at pharmacies. So okay. So another thing we also saw is that PrEP is in demand at private pharmacies and may be a good gateway to PrEP. So out of the 171 people eligible to receive PrEP, 95% of them did initiate PrEP. And afterwards, 20% of those that initiated PrEP came back to ask for PrEP, to be on PrEP to protect themselves. Okay, so the third question we asked is, if they use it, do they like it? So our pharmacy deliver PrEP service acceptable to clients and providers, and at what cost are clients, providers willing to purchase and provide these services? This second question is key because private pharmacies are not, is a private business and they're not paid by government. So somehow there's the service they provide, who pays for that service. So for acceptability, we use the theoretical framework of acceptability, which is a multifaceted construct with 7 components. And we measured both the clients and providers' agreements with this theoretical framework of acceptability constructs. Like we ask questions like, I like getting PrEP at pharmacies, agree or strongly agree, And we also included some open-ended responses to understand what they like or dislike about the pharmacy PrEP. So we saw that 94% of clients and providers agreed or strongly agree with the TFA, that's theoretical framework acceptability statements, indicating high acceptability of this model. When we looked at some of the things that the clients like about assessing PrEP in pharmacies, for example, one said, I like that it is easily accessible and the process is instant. Another said it is close to where I live and there is privacy. And also another female client said it's easier to get PrEP here than in hospital. Some of the providers also had this following to say, the clients are open and this gives me an easy time to deliver PrEP. Another said that this will make the community that live near a pharmacy know about the preventive measures that they can take to prevent the spread of HIV. So another thing we did was also to measure the costs around delivering this PrEP, and as well whether the clients are willing to pay, as well as whether the providers are willing to offer the services. So for the clients, 83% were willing to pay something, and the median, they are willing to pay 3.3 USD for a month's supply of PrEP. And all the providers are willing to deliver this service at a minimum of 1.6 USD to 2.4 to 4.1 USD to provide these services. When we did the micro costing to understand the cost of delivery, what it takes, all the costs involved in service delivery, we found out that it's cheaper to deliver PrEP in pharmacies compared to public clinics. And the cost drivers, looking at the details of the costing. So the cost drivers are mainly personnel. So in public hospitals, there are more people involved in delivery of the service. There are many stops, that the clients need to go, and more people involved. While in private pharmacy, just most of the pharmacies just have one pharmacist at the point, and maybe someone assisting. So it's cheaper in that sense, and also the administrative cost was lower. So in looking at this model, how do we really sustain this model? So we think that the clients are willing to pay $3.3. The providers are willing to charge less than that. And the true cost of delivery, if you remove the cost of the commodities, the HIV PrEP and PEP and HIV self-test, is $2.2. So, we think that the clients, so how we think that this model could work is, yes, we have on the left side, we have the public hospitals where you have PEP, PrEP, and HIV self-test, and we have a physician already paid by government. So we're involving private pharmacies to help deliver PrEP to make it easily accessible, and they assess PrEP, PEP, and HIV self-test from the hospitals, maybe using hub and spoke model, where you link the pharmacist to a particular hospital, and they report to the hospital for the commodity they collect. And they also consult the remote physicians if they need some help for this service. So this is how we think that this model could work. The fourth question we wanted to ask is, compared to what is currently allowed, what is the value? What is value add really? We know that we did a pilot and it seems to work, but we wanted to do more robust study to establish that this evidence we're seeing really holds true. So for that, we are doing a type 3 hybrid effectiveness implementation cluster randomized trial to assess this pharmacy and deliver PrEP. So we have 4 arms. So the first arm is pharmacy deliver PrEP with a fee. The second arm is pharmacy deliver PrEP without a fee, that's offered free of charge. The fourth arm is pharmacy deliver PrEP without a fee, but we have a HIV testing service counselor in the pharmacy delivering that PrEP service specifically, because the PrEP service takes some time, and we are afraid that the pharmacists might not have time, especially in peak period, to offer this service. So if you have someone dedicated to offering the service in the pharmacy, whether it will improve the implementation outcomes. Then the final is the standard of care. That's when the pharmacy providers identify someone that needs PrEP, they refer them to hospital. So this study is ongoing, and I think in next year, so we'll be able to see the results. So the last question we also asked is, what is needed to scale this pharmacy PrEP model up? So if yes, we establish that it works, how can we really scale this to the whole country? So for that, we are planning for scale with global goods and government alignment. So first, we are looking at expanding the scope of practice of the pharmacy providers. So we're working with, in this project, we're also working with the PIGO and an NGO. They are helping to develop tailored training materials for the pharmacy providers. We are also discussing with the pharmacy Poison Board and Pharmaceutical Association of Kenya about incorporating PrEP into PrEP and PrEP, everything about PrEP into degree program, PrEP delivery in pharmacy into that degree program, and continuing professional development. One issue will be the supply chain, to make sure that PrEP is available in pharmacy if you scale. So we are discussing with Ministry of Health about adding private pharmacies to the Kenya Master Health Facility list. So currently, pharmacies are not yet added in that list. So because all the donated products and all the for HIV care the master list is only contains public hospitals, so we have to really get pharmacies into that list. And we're also working with Ministry of Health to develop a framework for the public-private partnerships to ensure that this partnership will work seamlessly. A key issue is the issue of data sharing and quality assurance. So one thing that we are afraid of is if private pharmacies access public commodities, HIV self-test and PrEP and PEP, there's the possibility that they might not offer the service, but go and resell that. So we need to make sure that there's accountability of the service of the free product that they get. So in this project also, we are working with MyShamed. So they have developed an electronic medical record inventory management system for reporting these public commodities, and it's being implemented in the CRCT that is ongoing. So part of all the pharmacies involved, 60 pharmacies involved in CRCT are using this MyShamed application. Another thing we are concerned about is using HIV self-test, which is why HIV self-test hasn't been really used for diagnosis and all that because of false negative possibility of people not interpreting it correctly. So we are also working with Audrey. Audrey is an AI company in Seattle. They developed a system to validate the HIV HIV self-test results using photo AI, computer vision AI. So we just published and the performance of this AI computer vision, showing that it really does a good job. So we also incorporated their application in the MyShamed app to be able to validate the results that the HIV self-test results. So in summary, we think that PrEP is not having maximum impact on HIV incidence because yes, it's in country in most African countries, but it's not easily accessible to people that need it. And private pharmacies are promising delivery channels and could help Kenya as well as other sub-Saharan African countries to sustain its HIV response. So luckily, there's high interest from policymakers in Kenya, as well as funders, NIH, and they're talking about part of scale-up plan to involve pharmacies in delivery of some of these commodities, HIV commodities. And our pilot study suggests that the model is feasible, that is in demand, that reaches PrEP-naive population at risk and achieves outcome comparable to clinic delivery. And as of now, there's no playbook on how to really operationalize PrEP services in this setting. I think that our study is actually generating evidence on this pharmacy model's effectiveness and cost, and identifying training needs and exploring potential options for procurement, quality assurance, documentation, and reporting. And finally, Kenya is really a great test case for private pharmacy delivered HIV services. Apart from that, some of the counties in Kenya has very high HIV prevalence. They have well-developed and regulated private pharmacy network. And if this model is successful, could be adapted for other countries and repurposed for other interventions like the upcoming lenacapavir or Cabale for STIs, as well as HPV vaccination. Thank you very much. We want to acknowledge a couple of people that worked with us in this study, as well as the fundings we got from NIH Bill and Melinda Gates Foundation. Thank you very much.
Great talk, Abhinav. This was a very, very thorough investigation, and I like the fact that you addressed the trade-off between fidelity and adaptation, going from pilot to extended pilot, and then kind of going to the sustainment long term. And as any good implementation scientist would do, you go and start doing a randomized control trial to see what implementations work best going forward and scaling it up. So kudos for that. That's a great process. You also touched very well on one thought that you listed at the moment when I saw the randomized control trials structure, which was, is there a role for private enterprise involvement in defraying the costs, right? So government, private partnerships to make that scalability long term. So kudos, great talk. I will stop at these initial comments and open the session for questions.
Absolutely beautiful talk. I thoroughly enjoyed it. I have so many questions. I'll try to limit it to a few. My first question is kind of with, the paradigm of test to treat, right? So we're testing to treat. So I'm thinking about when you expanded over, once you're past pilot, you went into the expansion. There was the add-on of STI testing. And I did notice the setup, how you had, full-time licensed pharmacists and technicians with a private room for consultation. What type of STI testing did you do? What modalities were employed? And how did you do the handoff for clinical care for follow-up for treatment? This is like super fascinating to me that you were able to integrate this in your second phase. Can you explain a little bit about how you did that with the STI concerns?
Yeah, so thank you very much. As you can imagine, this is a very large project, and I came in as an health economist, so I will try to talk on and I came in at a point, so I will try to talk on what I know. So what I don't know, I think I can maybe check up and tell you later. So I know that the STI testing was, I think, suggested by Gates Foundation. They wanted to see if pharmacists could help with STI testing. And I know that in pharmacy, the pharmacist just collected the samples and sent it to a central lab. And when the results came out, those pharmacy clients were called and referred to a particular hospital in Kenya. So this is all I can say. It was just the STI also, it was just a point of collection. Samples were collected, tested in a central lab, and they were referred to a hospital. I know we didn't continue with the STI testing even in the CRCT because it was a headache. It was a lot of, it's a lot of work. And I think this is little I know because I joined the team when the pilot extension just ended. So I was brought in to help with the cost analysis and all that.
Thank you.
Good.
Hi, I'm Stephen John. I'm an associate professor and an implementation scientist within CARE here at MTW, the Center for AIDS Intervention Research. So I'm excited to hear that you'll be joining us and look forward to connecting with my colleagues. One of the questions that I had is, in your pilot and extension, it looked like 25% of potential clients were not ready to start PrEP despite their willingness to be screened for it. And so one of the big questions that I had was, what is your thought about how we can train pharmacists to do perhaps better or any sort of counseling related to patients to help them consider PrEP, especially within the context of, I saw that your hybrid trial, you just thought about hiring like a third person to do the test counseling. And I feel that my question is related to, especially related to cabotegravir for long-acting PrEP. pharmacies are a great way to be leveraged because of the increase in visits compared to oral PrEP. And so some of the things that we've been brainstorming here is about how to leverage pharmacies for cabotegravir in particular. And so I'm curious about your experience working on this team and with these pharmacists about our ability to train them to provide some of these sort of counseling components and perhaps motivational interviewing.
Yeah, thank you very much. This is a very good question. We did encounter a lot of problems involving the pharmacies in delivering this service. For example, I knew that some pharmacies found it very difficult to for example, talk with clients that have high risk, to talk to them about this service. So in some pharmacies, they didn't want to I mean, they got involved in the project, but they find it very hard to talk with clients, and especially to talk about the risk, HIV risk. So I agree with you. There are a lot of experiences that we have gotten, and we actually documented these experiences, and we are using them to develop training guide that we are proposing. And I'm just quickly trying to think about some of the other issues there. We had some issues with confidentiality. In fact, this morning I was in the meeting, in the project meeting. So it came up that one client that received PrEP, a lady that received PrEP, the husband came to the pharmacy, saw the tablets, saw the PrEP tablet, came to the pharmacy, and the pharmacist informed, that divulged what treatment, what the wife is receiving, which is not correct, and this will put the lady in danger. So for them to understand confidentiality and all that, there's a lot of trainings that need to be done. That's why we are also talking about if we really need to scale this up, it has to even start from the pharmacy schools to train them on some of these aspects of care, to understand some of these issues. Yeah, so we also, about the long-acting PrEP, Gates Foundation actually wanted us to start, they actually gave us funding to try to see if we can deliver Cabalate through pharmacies. And so we have already started the formative study when they pull back. So I think they pull back because Cabalate is not available, and maybe they want to pivot to lenacapavir. So yes, so we are also preparing our team is preparing to try to see if we can deliver long-acting PrEP through pharmacies. But thank you for that question. Yeah.
Excellent. Thank you.
Hello. Thank you so much for the presentation. My name is Lewis. I work here at MCW for the Center for Advancing Population Sciences. My question is a little bit about your clustered randomized control trial that you run, and I was just curious a little bit about how you decided upon the sample size for those pharmacies, and then also separately, I'm curious if you received any pushback. You mentioned a little bit about like the barriers and stigma to local treatment, especially in more rural communities. I'm wondering with the privately owned pharmacies, if there was any pushback from implementing some of these services because of the social stigma.
Okay, so yeah, so in the design of this, I know that for sample size calculation, they based the effect size from what we found out in the pilot extension. I can't remember now how we came up with these 60 pharmacies and 15 in each arm. Maybe I can check back on that and give you that answer. Yes, there are also people we're also facing some challenges with people in the community assessing assessing PrEP in the pharmacy. So I think there's some people that feel that the provider, because we're also documenting the modifications and the challenges we see. So some clients are not comfortable discussing their HIV risk behavior with pharmacy providers. So that one came out clearly. Some people feel that they know the pharmacists in the community and they don't trust the pharmacy enough to talk to them about some of these their risk issues and assess prep there. Yeah, so we also that challenge is there, but largely I think there are more people that want to assess prep in pharmacies than those that don't want to assess prep in pharmacy. So what we are seeing is that some people would prefer to go to the hospital to assess prep, while some will prefer to go to the pharmacies, do prefer to go to the pharmacies. And even those that prefer to go to the pharmacies are willing to even pay something, to offset the pharmacy providers' time. Yes, so there are some people that do not want to go to the pharmacies and are not very comfortable discussing and talking with the pharmacists. But I think the people that want to access are more than those people that don't want to access.
Thank you.
Yeah.
I have another question. So I see that you've implemented some AI use cases for part of this. Have you considered, and I don't know how much technology is available at the pharmacy sites, implementing some sort of AI technology where patients can access like a tablet or a smartphone or something to complete a risk questionnaire so that they don't have to have that one-on-one interface with the pharmacist? So it's kind of like they have a ticket. They go up to the pharmacist and they're like, from the comfort of my cell phone, I have this ticket that I'm going to show you. And then the pharmacist is like, okay, well, this is what we suggest. And then there's no conversation and there's kind of no stigma attached because it's a very benign result on their smartphone. Like, here's my ticket. And then the pharmacist can, subsequently talk about things. And then it's not the specific risk behaviors being called out. There's a lot more privacy. And they don't know why the patient is at risk. Perhaps the patient's mother is HIV positive or something. Like, there's different levels of stigma. So have you guys thought about doing anything like that where you would like use a technology tool to kind of reduce the human interaction and reduce stigma?
Very good question. So from the first pilots, we identified that using computer-assisted self-interviews might be better than one-on-one interviews. Now, I have to ask Katrina why it wasn't implemented, but I think there was no solution ready before they wanted to implement the pilot extension test. And again, I don't know why it was not implemented during the cluster randomized trial, but it was one of the things that came up strongly that if we implement it, it will help. Instead of one-on-one interviews, use maybe a CASI or give them a tablet to fill some of the to interview them. Yeah, thank you.
Comments, questions?
Another question, please, is I was wondering if you could speak a little bit about if you knew of other studies in other countries, but similar environments that saw similar results or different results and kind of compared the effectiveness of those interventions in private pharmacies depending on the local sort of cultural setting.
Yeah, thank you. So we know for pharmacy studies, I know of two going on in Kenya. So our study, Obla study and Gillian Pinte. So Gillian is using nurses in pharmacies to implement PrEP, while we think that the pharmacy provider can be trained to implement PrEP. I know there's another group in South Africa that tried delivering PrEP through pharmacy. I can't remember the team's name again, but the early results coming out, because I think it's same funding. We get the same funding from Gates Foundation. So I think the early findings coming out is showing that it's not working in Kenya. So I think, in South Africa. So I think South Africa is a different health systems, and the doctors, I think, are not open to pharmacy delivered PrEP. So this is also a very important saying that once the doctors are not open, are not ready to entertain it, it's really hard to implement it. So we're a bit lucky in Kenya because they already expressed interest express interest to use pharmacy prep, and I think the doctors are a little bit open to see whether it works. But I think in South Africa it didn't work at all, and I think that they're shutting down the study. I can find out from Katrina. Yeah, so these are the 3 studies I know going on in Africa. It's possible that for more people are now looking at pharmacies more and more, so I think maybe there might be other studies already starting.
Thank you.
Yeah.
This may have preceded you, but can you talk a little bit about the role of the local pharmacists had in the design of the study as important stakeholders?
Okay. Okay. So it's something we're trying to solve, and I think Katrina is doing very well. I think getting me to join her team is recognizing that idea of getting people, getting maybe Africans to also take part in the process. But she has done a very good job because I think if you ask me, I think the major design came from Fred Hutz, University of Washington, but there's input from Kemry from Kemry. So when we do things, we also send to them to review and to give input and all that. But I think I agree with you that stakeholder engagement, engaging them fully, from conception will make it work better because they see it as this is coming from them. I also agree that looking at this from someone from Africa, sometimes we look at some of these studies going on as this agenda. There's an agenda, they want to push this and that. Yeah, and that also explains when we started the Kabale study, wanted to get local ethics clearance. It took a while in Kisumu. So they kept on delaying and delaying. So later we learned that somebody somewhere is feeling that there's an agenda, they want to push this product to us. And yeah, but I think if they are really involved ab initio, it makes a lot of difference. Yeah.
Questions, comments?
On the same lines, what type of feedback did you get from the practicing pharmacists who I'm sure are extraordinarily busy? Did they feel that this was something that they could reasonably seamlessly integrate into their pharmacy practice, or were they further burdened or stressed?
Very good question. So what we are getting from the when we do qualitative research is that they say, yeah, that they're interested in implementing this. And I think that because they are being paid, they're receiving some money to offer this service, it could influence this service. It has influenced their interest in the living prep. One thing that came up, and it's also affecting the CRCT, including that's enrolling clients, is that when clients come during the peak period, period of pharmacies, they are told to come back later. And sometimes those clients do not come back for prep. So obviously what is happening is that when they come during the peak period, when the pharmacy providers are making sales and making money, they are turned down. It's only when they come in the mornings that the pharmacy is free, that the pharmacy providers do provide this service. And that's why we also have this other arm of including a HTS, HIV testing service counselor, to provide this service specifically to see whether it's going to help. And also with the time and motion study that I led, it takes about 30 to 1 hour to offer this service. So it takes a good chunk from the pharmacy provider's time. So they're ready to do it when the pharmacy, they don't have lots of clients, but during the peak period, they turn the clients now.
I don't see any questions from the Zoom land. Any other questions, comments from the room here or from the Zoom? Last chance.
I'm just thinking about next steps for future studies. I just was hoping if, so far, based upon the results of the study, if you had any plans in the works currently for more implementation studies with the sort of implementation science studies for the effectiveness of HIV or PrEP delivery.
Yes, I have some ideas I'm looking at seriously. I'm trying to develop for maybe R01 or so. So I'm thinking of doing in other settings. So most of the studies happening now is in East Africa and Southern Africa. It makes sense because the prevalence of HIV is very high. But there are other countries like Nigeria, although the prevalence is about 1.4, but it's a huge country, so there are lots of people. So in those kind of countries, we can still the same problem of PrEP being available, but nobody accesses it. So we can target some key people using pharmacy PrEP in areas that you have high high traffic areas, for example, where you have university hostels or where you have clubs and all that. So there are two models, kind of, the pharmacy providers offering this service or getting a nurse or HCS counselor providing this service. So I'm thinking of targeting pharmacies where you have high traffic zone and testing these two models to know which one will be the best fit for the Nigerian setting. Then we are also preparing for learn, to see if pharmacists could do that. It could be having a nurse in pharmacies to implement the service, to deliver the service.
Thank you.
Fantastic. Yeah. Thank you so much for joining us today and also joining us in the summer. Looking forward to be collaborating in implementation science and other projects. Thank you, Dr. Kunisa.
Thank you very much.
Have a good day.